Hello, guys. This is Om Patel, and today we're going to be talking about pancreatic cancer and treatment with Lynparza, which is a generic name for olaparib. And this is group one, consisting of Casey, CJ, Kieran, and myself, Om. Okay, so let's get right into it. Okay, so what I want to talk about is kind of the tissue, the cell types. Okay, so pancreatic cancer originates in the tissues of the pancreas. It's an organ located behind the stomach, and the pancreas has two main functions: it's the exocrine and the endocrine. So the most pancreatic cancers arise from the exocrine cells, particularly the ductal cells, making pancreatic ductal adenocarcinoma, which is the most common type of pancreatic cancer. And less frequently, tumors can originate from the endocrine cells, which can lead to pancreatic neuroendocrine tumors. Okay, so pancreatic ductal adenocarcinoma, which is the most prevalent type, accounts for approximately 90% of all pancreatic cancer. PDAC arises from the cells lining in the pancreatic ducts. And then the pancreatic neuroendocrine tumors, these are less common, but they present a distinct type of pancreatic cancer, which originates from the endocrine cells of the pancreas. And they can be non-functional or functional, depending on whether they secrete hormones or not. Okay. So biological subtypes, we have the classical versus quasi-mesenchymal subtypes. So within pancreatic ductal adenocarcinoma, there are recognized biological subtypes, the classical subtypes. Classical subtype is associated with the epithelial characteristics, while the quasi-mesenchymal subtype has more mesenchymal features, indicating a more aggressive behavior. KRAS mutations. Okay, so genetic alterations. So nearly all pancreatic cancers harbor mutations in the KRAS gene, which plays a crucial role in development of the PDAC. Another, in addition to KRAS, TP53 tumor suppressant genes are frequently observed in pancreatic cancer.
All right, so patients with pancreatic cancer tend to have mutations in their BRCA genes. The normal function of these genes are involved in the repair of DNA double-strand breaks through homologous recombinations. Whenever these genes have a mutation, then they're prevented from repairing the double-stranded breaks. Only a few, about 4 to 7% of the patients with pancreatic cancer have a germline BRCA mutation, and they're able to have a mutation in just one BRCA gene and still be okay. But when they get that second mutation, that's when they start to develop the increased likelihood of getting cancer. A hallmark of pancreatic cancer cells would be genome instability and mutations. Whenever the BRCA genes are mutated, then they're unable to fix these double-stranded DNA breaks, which results in gaps in the strand of DNA, which causes mutations. And the more mutations there are, it increases the genome's instability. And so our targeted intervention is a PARP inhibitor, and mutated BRCA genes are sensitive to these PARP inhibitors. PARP normally repairs single-strand breaks, but when there is no PARP, when it is inhibited, the single-strand breaks then turn into double-stranded breaks. And like I said before, BRCA genes are responsible for this, for that repair. But if one is mutated with the double mutation in both of the BRCA genes, then it cannot repair the cell, which then leads to cell death. And PARP inhibitor would be an example of synthetic lethality. If there's a defect in both of the genes, it's bad. It leads to cell death. But if there's just a defect in one of the BRCA genes, then it's okay because it relies on its redundancy pathway, its other pathway to fix the DNA strand break. So Lynparza, it should induce death in the cells with both defects while leaving the cell with just one defect alive.
Moving on to the epidemiology of pancreatic cancer and looking at the incidence and mortality rates, as well as the public health problems that this cancer can present. The current incidence rate of pancreatic cancer in the US is 13.3 per 100,000 individuals per year, and the current mortality rate is 11.1 per 100,000 individuals per year. Men are more likely to develop pancreatic cancer than women are, with mortality rates being very similar, with men also having a slightly higher rate than women. Both incidence and mortality rates increase with age, with the median age of diagnosis being 70 and the median age of mortality or death from pancreatic cancer being 72. Both rates have slightly increased over time as well, with incidence. It's increased from 11.12 in 2000 to 12.42 in 2020. And mortality has followed a similar pattern and has increased from 10.55 to 11.03 in that same time span from 2000 to 2020. Globally, the incidence rate of pancreatic cancer was highest in Europe with a rate of 7.7, and North America with a rate of 7.6. And globally, the place with the lowest rate of pancreatic cancer is Africa with a rate of 2.2. Here are two graphs that show us both the recent trends in mortality rates as well as the recent trends in incidence rates. They are both age adjusted and from 2000 to 2020 and are done by sex and include all races and ethnicities as well as all ages. And these two graphs help to show us how men have a higher rate of both mortality and incidence in pancreatic cancer. And this also shows us how the rates have changed over time from 2000 to 2020 and how they have slightly increased over time. This is an observational study on the risk of pancreatic cancer in breast cancer families from the Breast Cancer Family Registry. Hereditary breast cancer is a known risk factor for pancreatic cancer, which is described in the observational cohort study done in 2013, which analyzed the risk of pancreatic cancer in families with a high risk for breast cancer. And this was also based on the BRCA mutations. And they looked not only at the risk in families who carried either the BRCA1 or BRCA2 mutations, but also those families with mutation negative BRCAX, which means that they have hereditary breast cancer. However, they tested negative for either of the mutations. And it was found that families with BRCA1 mutations have a 4.11-fold increased risk of pancreatic cancer, and families with BRCA2 mutations had a 5.79-fold increased risk. And BRCAX families with two or more members diagnosed with breast cancer before the age of 50 had a 1.31-fold increased risk, and the rest of the BRCAX families had a 1.30-fold increased risk. And this study concluded that while having the BRCA1 or BRCA2 mutation can increase your risk of pancreatic cancer compared to the general population, members of breast cancer families who have hereditary breast cancer without either of these mutations are also at an increased risk of developing it compared to the general population. So in terms of quality of the findings of this observational study, this was a cohort study of 5,799 total families with one or more breast cancer cases, and they were divided into 4 separate groups. Those that tested positive for the BRCA1 mutation, those that tested positive for the BRCA2 mutation, and those who didn't test positive for either of those mutations, BRCAX. And this was broken up into 2 groups with families with 2 or more breast cancer diagnoses before age 50, and then the all remaining BRCAX families. The data on these individuals and these families were collected using either personal or telephone interviews or mailed questionnaires. And a standardized incidence ratio was used to estimate the relative risk of pancreatic cancer and statistical adjustments in the analysis were used to eliminate confounders. Their results suggested that there are no spurious results or bias in the study, especially when using the clinical information, not just the personal information. And this also suggested that the mutations are not the only, or the BRCA1 and BRCA2 mutations are not the only reason an increased risk of pancreatic cancer is connected to families with breast cancer. So while the findings may not be very useful in terms of prevention of this disease specifically, it does provide more information on the connection between hereditary breast cancer and pancreatic cancer risk based on the mutations. For families already at high risk of breast cancer with or without the mutations, these findings are useful in that these people can also be aware of and screen for potential pancreatic cancer as well, as an earlier detection and therefore earlier treatment may help, as the prognosis for this disease tends to be poor.
All right, guys, so I'm thrilled to discuss a promising avenue in cancer treatment, specifically pancreatic cancer treatment. This is a combination of olaparib or Lynparza, and it's a PARP inhibitor, and we're seeing how much of an impact it has when you combine it with gemcitabine. So this is a combination of treatments into one treatment. So eligible patients for this specific clinical trial had to meet a specific criteria. Patients must be 18 years or older, and there's Eastern Cooperative Oncology Group who performed this study, and their status had to be 2 or less, which means that they're ambulatory, which means they can move around and do stuff, do activities of daily living and able to take care of themselves. And additionally, life expectancy a minimum of 12 weeks. Okay, so to be eligible, patients should present clinical or radiological evidence. They presented clinical radiological evidence and histological evidence to confirm a malignant solid tumor refractory. Okay. All right, so let's see what happens, right? So there's 2 phases of this study. There's the dose escalation phase and there's the dose expansion phase. So the dose escalation phase, a total of 46 patients were enrolled. It's noteworthy that this includes the intent to treat population, where 44 patients received the intended treatment. So moving to the dose expansion phase, 23 patients enrolled and 22 received the study medication. So this phase aimed to explore the treatment's efficacy in a broader patient population, basically. So to take a closer look at the patient profile, demographics, and baseline characteristics, were generally well balanced amongst the participants. So to eliminate some bias. So the dose escalation strategy played a crucial role in determining the appropriate treatment dosage. There were strategy guides, self-exploration of various dosage levels to identify the optimal balance between efficacy and safety. The intended study population for this dose expansion phase was initially defined as patients with pancreatic cancer who had not received any chemotherapy. However, 2 patients with BRCA positive disease who had prior adjuvant chemotherapy for breast cancer were randomized to combination treatment. Okay. All right. So let's continue by looking at the overall response rate. In the dose escalation phase, the overall response rate was 10%, with 4 out of 41 patients demonstrating a positive response to cancer treatment. And then the dose expansion phase, the combination treatment showed an overall response of 27% with a 95% confidence interval ranging from 10.9% to 52%. This was observed in 4 out of 15 patients. So in comparison, the overall response rate for gemcitabine alone was 14%, and with a 95% confidence interval of 2.6 and 51.3, based on 1 out of 7 patients. So the observed difference in response rates between combination and gemcitabine alone was deemed statistically significant. So, all right. So this is looking at this figure, looking at the best percentage change in relative tumor size from baselines. The details are depicted here in figure 2. This provides a valuable insight into the anti-tumor response across the treatment groups. So examining the impact of BRCA mutation status on treatment process, they found that the BRCA mutation was available for a subset of patients. In the combination arm, 2 patients had BRCA1 mutation and 1 had BRCA2 mutation, and 3 patients were BRCA wild type. The BRCA mutation status was unknown to the remaining patients, unfortunately, limiting a comprehensive analysis based on this factor. So, despite these limitations, notable responses were observed in patients with known BRCA mutations. 2 patients had pancreatic cancer, and the BRCA1 mutation demonstrated a PFS response of 220 and 229 days, and OS responses of 332 and 401 days. So the patients with the BRCA2 mutation showed PFS of 213 days and OS of 540 days. So the median PFS and the OS for the combination arm were 163 days and 332 days. So respectively, for these findings provide a comprehensive overview of the overall response rate and treatment outcomes in the study. While the combination treatment demonstrated a higher overall response rate, the difference was not statistically significant. Further investigations into specific patient subgroups, such as those with BRCA mutations, reveal interesting trends that warrant deeper explorations. So overall, they were able to find a data that was statistically significant in reducing tumor size of patients with BRCA mutations in pancreatic cancer. So overall, they were able to prove that Lynparza or olaparib combined with gemcitabine is an effective treatment.
Okay, so we're going to get into some clinical information for pancreatic cancer and Lynparza. First, beginning with the subtypes, we have the squamous subtype. It has a 31% incidence rate. It has the most diverse gene programming, which also correlates to a worse outcome for disease. This can be represented with the survival rate, which compared to the other subtypes is considerably lower. It's almost half of the other survival rates. Here next, we have the pancreatic progenitor subtype, and that has a 19% incidence rate. It only has 1 gene program, and it has a high impact on several transcription factors that take place within the body. Next, we have our immunogenic subtype, which has a 29% incidence rate, 4 gene programs, and a heavy impact on immune cell function. And restoration of the immune system is crucial for the survival rate of this subtype. And then lastly, we have the aberrantly differentiated endocrine exocrine or ADEX subtype. This has a 21% incidence rate, 2 gene programs, and exocrine function and secretion and development of beta cells are the focus of what's happening here with this subtype. For prognosis, we have roughly a 1-year mortality rate of 24% and a 5-year mortality rate of 6%. The propensity for regional spread and metastasis is 80%, which is quite high. And then some of our treatment protocols are surgery, radiation therapy, chemotherapy, chemoradiation therapy, and targeted therapy. Some of the things we'll be talking about more so heavily would be chemotherapy and then the targeted therapy. This next slide, we're talking about staging. So there are 2 forms of staging that I've included here. On the left-hand side, you have your breakdown that you are commonly seeing, which is the 1, 2, 3, 4, and this one has a breakdown of 4A and 4B. And then on the right-hand side, we have a little bit more of like a detailed staging system, and it's called the TNM Pancreatic Cancer Staging System. starting with primary tumor, which breaks down into several sections, regional lymph nodes, and distant metastasis. So you can just take some time to review that here. The primary tumor obviously has many categories, so this kind of breaks it down a little bit more than that system that you have on the left. For patient experience, we're going to start with the presenting symptoms. The main one here is pancreatic exocrine deficiency. That can be shown with something like steatorrhea, which is an increase of fat in your stool, malabsorption, weight loss, abdominal pain and discomfort, or bloating in the abdomen region. You'll also see jaundice. You can have a dull pain or non-specific pain, nausea, anorexia, and onset diabetes. Some drug combinations that are used to treat this. Well, firstly, on the right-hand side, all the way to the right, you have some examples of drug treatment options, but the ones that I've highlighted are the drug combinations that are used. And one thing that I want to focus on is gemcitabine and the combinations that are used with that, because that correlates to the resistance issue that you run into with pancreatic cancer and pancreatic cancer treatment. So one of the more common and difficult forms of resistance is gemcitabine resistance. This is problematic because of its wide use. Not only is it used in these drug combinations, but it's also used in other chemotherapies as well. The exact reason for why this resistance is developed is unknown, but researchers know that it involves several transcription factors that correlate to the overall resistance that's developing. Moving on. All right, and now we're going to talk about Lynparza. So with Lynparza, there are some criteria that are necessary when looking at if it would be applicable to a patient with pancreatic cancer or not. Starting off, you need to have or be suspected of having the deleterious germline BRCA mutated gene for metastatic pancreatic cancer. This is just the starting criteria point for how Lynparza will be able to impact and hopefully benefit you. Secondly, you need to have a status of disease considered to be stable after your initial chemotherapy treatment, and this timeline needs to fall within 16 weeks. So what Lynparza here is actually doing is more of a maintenance of this status, trying to first obtain the desired response for the pancreatic cancer, and then using the Lynparza to maintain that desired response without any changes that are undesired. So that's kind of what we're looking at when we're incorporating this drug. Some off-target effects of this drug are nausea, vomiting, and abdominal pain. Just those things that you see with most drugs, fatigue, diarrhea,